Hello everyone, welcome to another episode of Clinical Case Discussion. Today we will start the groin swelling. So the first part will be dealing with the basics. So firstly, we will learn about what is groin. So it is nothing but that part of the body that lies between inguinal crease infralaterally and the waistline superiorly. Just to summarize, if you take this is the outline of the abdomen, where you are having the junction of abdomen as well as this thigh. This part is called usually groin. It has also alternatively been defined as that part of the body that is covered by the undergarments. So you can take this part is usually called groin. Okay, right. So it's a must known definition. What is hernia or define hernia when an examiner asks you? We don't have the privilege of changing even a single word when we are learning the definitions. So hernia is defined as an abnormal protrusion of a hole or a part of viscous through a normal or an abnormal opening in the wall that contains it. I'll just try to make it simple how to remember it easily. Let's say, for example, this is the abdominal cavity we are talking about, and this is the umbilicus, and your deep ring as well as superficial ring is something that is present. This is a normal opening that is present. Let's say, for example, a patient has been operated previously, and this is the incision. If hernia occurs through that incision, it is called incisional hernia. So you can remember hernia is defined as an abnormal protrusion of what? A hole or a part of viscous. Let's say, for example, this viscous can be a momentum or a bowel, which are more commonly seen, or it can be other things also. So, where is it herniating through? Through a normal opening, like inguinal canal or deep ring, or an abnormal opening, like an incision in which through which this hernia is happening. Where is this abnormal or normal opening present? This is the abdominal wall we are talking about. So in the wall that contains it. So you can remember like this easily. Okay, right. So what is Hasselbalch's triangle? This is also called inguinal triangle. We need to remember the boundaries. So as you know, the triangle has got three parts. You can see here the medial boundary of Hasselbalch's triangle is formed by lateral border of rectus abdominis. This is the rectus abdominis muscle. This is the lateral border of rectus abdominis. And the lateral border of triangle is formed by inferior epigastric vessels. So they can ask you inferior epigastric artery is a branch of. You can remember simply just rearrange the letters. IEA is a branch of EIA, external iliac artery. So this is the external iliac artery where your internal inferior epigastric artery is coming through. Okay, right. So this is the lateral boundary of Hasselbalch's triangle, inferior epigastric vessels, and the floor of the Hasselbalch's triangle is formed by, as you can see here, this is the iliopubic tract. This is the floor. So these are the three important boundaries of Hasselbalch's triangle. The clinical significance of this Hasselbalch's triangle is that there is a potential weakness here, and whenever a direct hernia is happening, it happens through this particular Hasselbalch's triangle. So this is directly happening through the posterior wall. Okay, right. Next. So there are certain important landmarks we need to understand. Before that, we need to understand what is inguinal canal and all. So please understand, if you take this is the outline of abdomen. So, where is deep ring located topographically? That will be the question. Please understand this is the anterocephalic spine, and you have pubic symphysis or pubic tubercle here. 1.25 centimeter above the midinguinal point. We will see what they are. So, 1.25 centimeter above midinguinal point is your deep inguinal ring. Please understand there are two important points we need to understand. Midinguinal point is different from midpoint of inguinal ligament. You know that external oblique muscle comes here and will condense between your anterocephalic spine and pubic tubercle to form the inguinal ligament. So here, where is extension of this iliopubic tract or external inguinal ligament? So it is between anterocephalic spine and pubic tubercle. So pubic tubercle and anterocephalic spine. Between these 2 points is your midpoint of inguinal ligament. You can easily remember what is the extent of inguinal ligament. Midpoint of those two landmarks is called midpoint of inguinal ligament. Midpoint of inguinal ligament. That is one common question the examiner will ask you. So this is mid-inguinal point. What is the difference between anterior suprailiac spine and pubic symphysis? Between these two landmarks is called mid-inguinal point. So where is deep ring located? 1.25 centimeter or half inch above the mid-inguinal point. Okay, right. Now, superficial inguinal is present just above the pubic tubercle. So, just above the pubic tubercle, we have got a triangular slit. It is a triangular slit, whereas deep ring is a oval defect. Okay, and saphenous opening is present 4 centimeter or 3.75 centimeter below and lateral to the pubic tubercle. Somewhere here, you will be getting your saphenous opening, where your great saphenous vein is draining into common femoral vein. Okay, right. So we need to understand layers of anterabdominal wall to understand more about the inguinal canal. So there are 10 layers in case of anterabdominal wall. I'll just list out here. So first one is skin, then subcutaneous tissue. Third one is superficial fascia. It has got two layers. Superficial fatty layer called Camper's fascia. Deep membranous layer called Scarpa's fascia. Then next is your external oblique, internal oblique, transverse abdominis, fascia transversalis, which is also called transversalis fascia. Then extraperitoneal pad of fat or preperitoneal fat, preperitoneal fat. Last is your parietal peritoneum. These are the 10 important layers we need to remember. So you can see here, this is the skin. Superficial fatty layer called Camper's fascia. C comes first, S comes next. You can remember the alphabetical order. So deep membranous layer called Scarpa's fascia. Both are part of your superficial fascia. Then comes your external oblique, internal oblique, transverse abdominis, transversalis fascia or fascia transversalis, extraperitoneal fascia or preperitoneal pad of fat, then parietal peritoneum. These are the 10 layers of anterabdominal wall. If you understand this, there is another important point we need to remember regarding anterabdominal wall. Between your internal oblique and transverse abdominis, neurovascular bundle is going. You can see here, this is the neurovascular bundle going between internal oblique and transverse abdominis. Please understand this point. We will discuss this in past history. So, where is this present between? So, between internal oblique and transverse abdominis, neurovascular bundle is going on. Okay, right. Next. So they will ask you a few important points regarding ileoing law. So first one is origin, then course, then what type of nerve it is, and supply. What does it supply to? So please understand, origin of ileoing law starts from L1 ventral ramus here. So you can see here, this is the ileoing law we have got. This is the ileoing law. So comes from the ventral ramus of the L1. Then course. You can see here in the picture, it will start lateral to this psoas major as well as quadratus lumborum. In between these lateral border of psoas major, it will exit and then it will travel inferiorly. Then it enters into the plane between internal oblique and transverse abdominis. You can see here, this is the internal oblique muscle we have got, and this is the transverse abdominis. So between internal oblique and transverse abdominis, it is traveling through, then it will enter into the inguinal canal directly from the posterior wall. You can see this is the superficial inguinal ring and this is the deep ring. So it enters the inguinal canal directly from the posterior wall. Then it will exit through the superficial inguinal ring. Then it will supply to the different things. So we will see what it is. So that is the course of ileoinguinal nerve. It is a mixed nerve. Please understand, it is a mixed nerve. So it has got two things, right? So one is sensory, another one is motor. So sensory, it will supply at the medial and superior part of these genital organs, superior most part of the genital organs, as well as the supromedial aspect of the thigh. Okay, right. Motor, as I just now I have told you, it is passing between internal oblique and transverse abdominis like this. So it will supply to the both muscles. Okay, so motor is to internal oblique and transverse abdominis. That is the supply. Okay, right. Now coming to inguinal canal. If you have understood the boundaries of inguinal, if you understand the boundaries of inguinal canal, it is easy to understand the surgical part. To understand inguinal canal, we need to have an idea about anterior abdominal wall layers. So we will see what is inguinal canal basically. It is nothing but a a musculo-aponeurotic canal. The name itself says muscles and aponeurosis. What is the aponeurosis we are talking about? External oblique aponeurosis. So it is present between two important rings. One is deep ring, another one is superficial inguinal ring. So deep ring is nothing but a oval defect present in which layer? Fascia transversalis. Okay. Whereas superficial inguinal ring is it's more like a triangular slit which is present in the external oblique aponeurosis. So, superficial inguinal ring is a defect in external oblique aponeurosis. Now, it is an oblique canal present between these two rings. Now, coming to the boundaries, please understand the anteriormost boundary is formed by external oblique, whereas very laterally you have got this internal oblique. Okay, now, so this is the anterior boundary is formed by external oblique aponeurosis. Now, coming to the posterior one, as you can see here, first one is posterior to anterior, we can remember. So first one is fascia transversalis, then is conjoint tendon, I'll explain that. Then reflected part of inguinal ligament. You can remember FCR, just like TCR. So fascia transversalis, conjoint tendon, reflected part of inguinal ligament. How is this conjoint tendon is formed? Please understand. Lateral to the inguinal canal, you have got this is internal oblique, this is transverse abdominis. Just remember the order of anterior abdominal wall layers. So external oblique, internal oblique, transverse abdominis, fascia transversalis. So lateral to the inguinal canal, internal oblique and transverse abdominis are present separately. As they cross the inguinal canal like this, like an arch, they are fusing together to form a single structure called conjoint tendon. So this conjoint tendon is nothing but fusion of internal oblique and transverse abdominis. Now you can remember easily the roof of inguinal canal. It is nothing but arched fibers of internal oblique and transverse abdominis. Then floor of the inguinal canal is formed by, please understand, floor is formed by, it is nothing but grooved part of inguinal ligament. Inguinal ligament is again a condensation of external oblique muscle, aponeurosis. Okay, so it is the floor of the inguinal canal, right? Next, coming to what are the contents of the inguinal canal. Please understand at this junction there will be two questions. So first one is what are the contents of inguinal canal. Second question is what are the contents of spermatic cord. So please understand, canal has got two important structures. One is ilioinguinal nerve. Second one is spermatic cord in case of males, whereas in females it is round ligament. Okay, these are the contents of inguinal canal. So when you are doing the surgery, when you open the external oblique aponeurosis, it means that you have entered into the inguinal canal. There you get these two important structures. Now the second question is what are the contents of spermatic cord? So you can remember the contents of spermatic cord easily. You know that in case of males, the main important structure is vas deferens. Apart from the vas deferens, you can remember this three arteries. So first one is testicular artery, second one is artery to vas deferens, then is your cremasteric artery. And the two important veins, that is nothing but pamponiform plexus of veins and veins corresponding to the arteries. Then coming to the nerves, so it is just like a neurovascular bundle and lymphatics. Just remember like that. So neuro, vascular means both arteries and veins. So neurovascular bundle along with lymphatics and others. Okay. So now, sir, mainly genital branches of genitofemoral nerve and testicular plexus of sympathetic nerves. These are the two important nerves. Then what are the important lymphatics of the testis also will travel through that. And I told you in the first place vas deferens. So these are the contents of spermatic cord. You can remember this picture. So the coverings of spermatic cord will be external spermatic fascia, cremasteric fascia, internal spermatic fascia. So this is derived from external oblique muscle. Cremasteric fascia is derived from internal oblique muscle or fascia. Internal spermatic fascia is defined from fascia transversalis. Please understand, transverse abdominis. The name itself says it is confined to abdomen. So transverse abdominis will stop at the level of abdomen, whereas fascia transversalis will come to the scrotum through this internal by by giving rise to internal spermatic fascia. So you can see here testicular artery here, then cremasteric artery is there, pemperiform plexus of veins. This is the ductus deferens or vas deferens we were talking about. So you can remember this picture to understand the contents of spermatic cord, right? Next. So we have finished the anatomy part. Now coming to the physiology part. If we have understood the boundaries of inguinal canal, we can easily understand the mechanisms preventing hernia formation. So the first one is, as you know, inguinal canal is not a straight canal. It is an oblique canal. So Obliquity of inguinal canal is the first and most important factor which is preventing the hernia formation. Second one is shutter mechanism. To understand this, please understand, you might have observed shopkeepers closing the shutter of the shop, right? So similarly, I told you the roof of the inguinal canal is formed by arched fibers of internal oblique and transverse abdominis. So whenever there is rise in intra-abdominal pressure, this internal oblique will close the inguinal canal by contracting like a shutter. That is called shutter mechanism. Then, if you know, this is the anterior boundary and this is the posterior boundary. Whenever there is rise in intra-abdominal pressure, this anterior wall and posterior wall will get approximated like this. That is called like a flap. That is called flap wall mechanism. So anterior and posterior wall are closing together like this. Then whenever there is rise in intra-abdominal pressure, the cremaster muscle will contract. So this spermatic cord will come and plug the. So it is coming like this. So whenever cremaster is contracting, this spermatic cord will come and plug this superficial inguinal ring. That is called ball valve mechanism. Next is slit valve mechanism. Like a, there is a lens cap. So this there will be a slit valve to this lens of the camera. So whenever there is rise in intra-abdominal pressure, this will close like a slit valve. So it is nothing but the crura of the superficial inguinal ring. They will contract like this. So the crura of the superficial inguinal ring will close like a slit valve. So these are the important mechanisms which are preventing the hernia formation, right? Now, coming to lap anatomy. So whenever we are talking about laparoscopic surgery, there is important laparoscopic anatomy we need to understand. So let's say, for example, if you take, this is the abdomen. So this is superior, this is inferior. Let's say, for example, the surgeon stands here and is viewing the pelvis from this view. So this picture is nothing but this kind of a view. Okay. So you can see here, this is the medial part, this one, and this is the lateral part. So there are two important triangles we need to understand. One is doom and another one is triangle of pain. They are adjacent. So you can see here, this is the vas difference we are having. So this is nothing but this structure is vas difference. So this forms the medial boundary of triangle of doom. Okay. So the lateral boundary is formed by gonadal vessels. This is a testicular artery and testicular vein. In case of females, it will be formed by ovarian. So gonadal vessels. That is the lateral boundary of triangle doom. So medial, lateral, and base. Okay. So triangle of doom medial boundary is vas difference. Lateral boundary is gonadal vessels. The lateral boundary of triangle of doom, as you can see here, the lateral boundary of triangle doom is nothing but the medial boundary of triangle of pain. So the medial boundary is formed by gonadal vessels here. And lateral border of your triangle of pain is formed by iliopubic tract. Iliopubic tract. Nothing but modified grooved part of the inguinal ligament. So the base of both triangle of doom and triangle of pain is formed by reflected portion of peritoneum. Reflected portion of peritoneum. That is a common boundary for both the triangles. So this is the base formed by. So you have reflected a portion of the parietal peritoneum. That is forming the base of both triangles. Okay. So this is triangle of doom where you are having main vessels like external iliac artery and external iliac vein. If you accidentally injure any of these contents in this triangle, it will lead to catastrophic bleed. That is why patient will be dying. That is why it is called triangle of doom. Here you have got important nerves like lateral cutaneous nerve of thigh, femoral nerve, then anterior nerve of cutaneous nerve of thigh, etc. These are the important nerves present in triangle of pain. So if you accidentally damage any contents of triangle of pain, it will lead to so much pain after the surgery. That is why it is called triangle of pain. Okay. So these are the two important triangles and contents. Now coming to, there is an important thing called corona martis or crown of death. Crown of death. So this is nothing but an anomalous anastomosis present between inferior epigastric artery and obturator artery. Obturator artery is a branch of anterior division of internal iliac artery. So you can see here, this is the common iliac artery, and this is internal iliac artery. This is external iliac artery. This is internal iliac artery. So the external iliac artery, internal iliac artery. One of the anterior division. So obturator artery is a branch of anterior division of internal iliac artery. This is forming an anomalous connection here. The what is crown of death or corona mortis? It is nothing but, in few people you will see this anomalous anastomosis between inferior epigastric artery and obturator artery. Okay, I'll just simplify it here. So this is the abdominal aorta, this is common iliac artery, this is internal iliac artery, this is external iliac artery. I told you cremasteric artery is a branch of external iliac artery. So this is your inferior epigastric artery. So this is internal iliac artery. This is external iliac artery, common iliac artery. So internal iliac artery has got again posterior division and anterior divisions. Anterior division again one of the branches is your obturator artery. O for obturator artery, I for inferior epigastric artery. So there is an anomalous connection between. This is the anomalous connection. I'll just write here. So this is the anomalous connection between inferior epigastric artery and obturator artery. So that is called crown of death. Why is it important? During the surgery, if someone misses noticing this important crown of death or corona mortis, if I accidentally damage this vessel, there will be torrential bleed. Okay, that is why this is called corona mortis. Okay, crown of death. Right? Thank you.